Thank you. So my talk is going to be about facilitated femoral access in TAVR. So it has been evolution in using of alternative access since the first in-human TAVR done transeptal antegrade in 2002, followed by doing transfemoral retrograde in around 2005, then transapical subclavian, transaortic, and followed by transcarotid and transcaval. And we know basically from the TVT registry that using transfemoral in addition to hospital volume actually has associated with better outcome when compared to non-femoral accesses in TAVR. And there has been actually a selection in use of alternative access when we look at the registry STS-ACC TVT registry for TAVR. Then in the States, we can see that from 2015 to 2019, actually, most operators actually tried to avoid using transapical and direct aortic, and that was actually because of the high mortality and complications associated with these alternative accesses. And using actually auxiliary and carotid access has been used since that time. Now, looking at recently published in 2022 about looking at some selection of the same registry. So when we compare actually using transfemoral accesses and compared to transaxillary and transcaval, we can appreciate that in around more than 7,000 patients, the rate of stroke and TIA was around 2%, bleeding was 4%, and death was actually 1%. While when you look to alternative accesses, speaking about transaxillary, high rate of actually stroke and TIA and bleeding, around 13%, and around death of 4%. Better to some degree with transcaval, the reported stroke was around 3%, bleeding was 10%, and death was 4%. So very important to appreciate calcified iliac and femoral arteries. And the presence of severe calcified atherosclerotic lesions in these arteries actually preclude use of TAVR in around 10 to 15 patients. Very important also to appreciate when you're dealing with non-calcified arteries that because of the stretching ability, you can do actually accesses with large bore accesses with acceptable lumen to TAVR sheath the outer diameter up to 0.75%, while in calcified arteries, because these stretching ability is lost, then you have to have at least 1.25% ratio. Having said that, actually, the best modality nowadays to use that actually to going with lithotripsy, but do we have any data to using lithotripsy for facilitating access prior to TAVR? So we have two important registries. The first one actually is a cohort analysis from the Disrupt BAD3 trial, done in around basically more than 1,500 patients. But when you look to the iliac subgroup analysis, around 118 patients and 200 lesions. So the main indications for using IVL in iliac arteries was for claudication and treatment of peripheral symptomatic artery disease. And few of them actually they have indication to do for large bore access. IVL size was in this registry, basically the most size was around 7 millimeter, followed by 6.5. When you look to the overall reference vessel diameter was around 7.3 millimeter, and mostly they have severe stenosis with diameter stenosis of 83%. PTA was used more commonly in the patient with claudication compared to access. And as you can appreciate, DCB and drug-eluting stent was used only in patients with claudications. Cover stent used in around 36 lesions and around 3 lesions in patients for access. More importantly, actually looking at the final results after intravascular lithotripsy in those patients, actually immediately there is a significant reduction in stenosis from around 80% to 12%. And you could appreciate also the safety profile here with around severe dissection, perforation. It was actually 0 in this cohort analysis. Looking more specifically, actually recently published 2022 from Italy and France in around 108 patients. Looking specifically in this registry for the using of IVL to facilitate the access. So it's basically done mostly for common iliac and external iliac arteries. The target lesion diameter was around 4.6, and mostly they have actually calcium severe as identified by CT with calcium arc around 317. So elective IVL was done actually upfront in around 70 patients, 70%, while 30% they have as a pill out. And you could appreciate that actually the most common size was around 7 millimeter, and around 50% of them, they have conventional post-dilatation with balloon, and the balloon used mostly around 8 millimeter. So the delivery of the TAVR system was successful in all patients, in 100%, and it was done also in the same procedure index.
You have 30 seconds now, license.
Sure.
You have.
Okay. So done in around 100%. You could appreciate also the safety profile for this using IVL was really good in this trial with only 1 perforations. So very important key points to remember: to use IVL prior to TAVR, always ensure proper CT angiographic screening for the calcium and diameter. And when you use IVL in small artery access, try to avoid ballooning before IVL because this might cause actually dissection and you have to stent after that. Very importantly, to not put stent before delivery of the valve unless you have perforation or flow limiting major dissection. Otherwise, the valve basically will interact with the stent and might cause dislodgements or the embolization. So lastly, I'm going to share with you this very interesting actually case report done by Dr. Hussam Noor and his colleagues. Showed basically importance of preparation before doing any TAVR case. So this patient has actually a polymer emboli from the coating that covered the sheath, leading to actual intestinal ischemia, digital infarction. Hopefully the patient recovered and discharged from the hospital.
Okay, Abdullah, thank you very much for